Okay, so tonight we have Dennis Bourbeau with us. He is an investigator at the Cleveland FES Center, a biomedical engineer at the VA Medical Center, staff scientist at the Metro Health Medical Center, and assistant professor of physical medicine and rehabilitation with Case Western Reserve. Tonight he is here to speak with us about developing new devices for managing bladder and bowel health after spinal cord injury. So Dennis, you should be able to share your screen, and welcome and thank you.
Thank you. Let me get my slides up. You want a presentation? All right, can you see my slides?
Yes.
Excellent. All right. So again, thank you for having me, everybody. This is what I'd like to do is facilitate a kind of discussion here. So I'll present a few slides and we'll take a break for discussing the topic a bit and then go on to the next piece. So we'll be talking about bladder and bowel. And I start with a bit of the anatomy and physiology. And then I'll go into what some of the cutting edge research is showing us. So first, just talking about bladder health. So there's two functions: storing the urine or emptying the urine, and it is meant to be a coordinated thing. So if you'll bear with me, this is a classic textbook drawing cartoon showing the brain and spinal cord broken up into its general sections of the cervical spinal cord, thoracic, lumbar, and sacral. So if someone gets an injury at their cervical cord, at their neck, then these nerves and the pathways of the spinal cord are still intact below that lesion level, but they're cut off or disrupted with their connections up to the brain. So this gives us a simple map on the left for understanding what that spinal cord lesion may do to affect the bladder control. And here, where there's only basically three nerves that we look at: the hypogastric nerve, the pelvic nerve, the pudendal nerve. And some of you may have heard about devices or things that target the sacrum or the sacral roots, because a lot of the nerves will flow through there. And the things that we think about in research or in medicine are what is the bladder doing to maintain low pressure, and especially during holding of urine. And the sphincter muscle around the urethra is meant to maintain some tone so that there's storage and continence. And then when it's time to empty, you have a simultaneous contraction of the bladder and relaxation of the sphincter. So what we're looking for ideally is that kind of coordinated behavior of the bladder and the sphincter muscle. And then after a spinal cord injury, mostly what I'll be talking about is upper motor neuron, but I want to acknowledge that there's lower motor neuron injury where all of these organs become basically relaxed or flaccid. But if we but with upper motor neuron, which what most people with spinal cord injury will be experiencing,
Very big if you take a screenshot,
is there'll be overactive bladder contractions. So bladder contractions when you don't want them, which can result in leaks. There will be the sphincter muscle will contract when you don't want it to. So if you're trying to empty your bladder and your sphincter muscle is contracting, you may need to use a catheter to get past that sphincter and get your bladder emptied. There may be diminished sensation. So maybe you're feeling sensation of bladder fullness, but it's in your abdomen or your shoulder. And then we worry about the secondary effects that are really important. So if the urine is not able to get out of the body, it may go up into the kidneys. And also if there's a lot of pressure in the bladder, it could trigger autonomic dysreflexia. If you haven't heard of it, I'm happy to talk about that too. So there are a number of adverse and significant health and quality of life issues here for managing this. So to manage it, the different catheterization strategies. There are drugs that will try to keep the bladder calm. So maybe an anticholinergic like oxybutynin to try to weaken or stop the bladder contractions. And then if those aren't working, there may be a surgery. So there could be a stoma or suprapubic catheter for emptying, or a pouch of bladder augmentation surgery that takes a piece of colon and staples it to the bladder. And these are the tools that the clinicians have. This is what we're able to do. And unsurprisingly, that's just not good enough, really. So they don't really address the issues, the functional issues, and they have a number of drawbacks. So we, a group of us, surveyed several hundred people with spinal cord injury, asking them about, we had a multi-page survey asking questions about how they're managing their bladder and bowel health. What are their goals? What are their priorities? And so when we asked them about their challenges associated with their bladder, just in the last year, what kinds of things came up? Did you get a urinary tract infection? Did you get urinary incontinence? Did you have autonomic dysreflexia? So we're seeing a lot of urinary tract infections. We're seeing a lot of urinary incontinence. We are seeing clogged catheters and kidney stones. And this amount of autonomic dysreflexia is, too many people were having autonomic dysreflexia episodes. We also asked them what their priorities were for getting bladder function back. And this is a bit tricky to ask because, there's a saying that's been attributed to Henry Ford. I don't know if he was actually when I said it, but if I asked them what they wanted, they would have told me a faster horse. So on the research side, there are different things that we can try to do for maybe restoring function or helping, but we may not have the right definition for what success looks like. So we were trying to get a sense of what does success look like from the point of view of someone living with neurogenic bladder. So we're hearing that they wanted to empty the bladder without having to use a catheter. They wanted to maintain urinary continence and be free of medical complications like autonomic dysreflexia or urinary tract infections. They wanted to be independent with their bladder. So this was not ranked as highly as maybe some of the other ones, but we saw a lot of desire for independence in how they manage the bladder. And so these kinds of responses drive what happens in research. When we understand this, we can try to focus on these goals. And so what I'd like to do is just take a moment to open up the discussion about what is going on with neurogenic bladder. If anyone wants to volunteer their experiences, their concerns, do they have any reaction to anything that they're seeing in the first few slides? And I'll open it up to discussion. And I realize it may take a minute for folks to maybe gather the courage or think of something they want to ask or say or contribute. Does anyone have any challenge with the way they manage their bladder, or does everyone here feel like they have a pretty good routine with their bladder using the tools that they have? Is there anyone that doesn't feel like they've got a routine figured out and they're all set?
This is Rhonda Volansky. I got a suprapubic catheter because I'm a T3, and it's wonderful in some aspects. In other ways, it really stinks. And this might sound stupid, but what is that autonomic dysreflexia?
That's not stupid at all. Thank you for asking. So autonomic dysreflexia, not everyone will hear about this, and hopefully that's something you have to experience. But what it means is if there is something that could be causing you damage, let's say, or discomfort, and it's coming from below your lesion, maybe you cannot feel it, but your circulatory system, that your blood vessels will respond automatically, and your blood pressure will increase. So let's say you stub your toe, or your bladder's getting too full, or you have a catheter, a suprapubic catheter that's clogged, or something that should be causing pain or damage, whether or not you can feel it. Your blood pressure, your blood vessels below that lesion will constrict, the blood pressure will go up, and you'll start feeling maybe dizzy or lightheaded or flu-like symptoms, or but it becomes a cardiac event. It's something that some people may have autonomic dysreflexia and not realize it. So it's just a good thing to check with your doctor if you have any concerns, or if you want, further education about that. Some folks, are aware of what those issues are, those symptoms. They'll say, oh, I feel like I'm getting symptoms of autonomic dysreflexia, and so now I got to look around for what might be causing a problem and address it. I've heard that usually it's something that may be with, something like a kinked catheter or clogged catheter, something like that, or maybe their foot is stuck or something, or there's damage somewhere, and so it's usually good to kind of do a check of your body to see what's going on. But that's a pretty important topic because autonomic dysreflexia, can be dangerous if you have a precipitous and insignificant rise in blood pressure. That's something to be aware of if you're living with that or not, and if you are, understand what it is and how to manage it. Yeah. And if anyone else wants to jump in on autonomic dysreflexia, please do. It's a pretty important topic.
So you have physical symptoms. I don't ever sweat. I have gotten plugged before, and I've felt really strange. And they put the O-meter thing on my finger, and they'd say, well, that's fine. And I guess if that's fine, everything else is fine. What can they do medically to this if your body isn't showing it, like in a cold sweat? How do they find out that you're having that?
So they're gonna, so if they want to look for your blood pressure. So something as simple as putting a blood pressure cuff around your arm, measure that blood pressure. If it is over what is normal for you, there's also a range, and I don't want to give wrong information, so I'm not going to speak up on what the range is. That's something that can be Googled. But if it's out of a healthy range, let's say your blood pressure is too high, the first thing to try to do is figure out what is causing it and address that. So if you're presenting with an elevated blood pressure, the first thing they're going to do is check you out below your lesion level to see, is there something that's causing damage or pain? And think about that. There's a whole protocol to go through. But if you're dealing with it on your own and you can feel it, then yeah, your first course of action maybe, just check yourself. Is there something that could be causing pain or discomfort or damage, and fix that.
Can I say something?
Please do, Don.
You have to know, every individual has to know about AD. That AD is going to be a personal thing. And many of you who are experienced paras, quad, or tetras will understand this. You need to know about AD because the other people don't know about it. So that when you have high blood pressure, you got to know that you got a sore on your bottom, or you got to know that your foot is bent, or you got to know that you got a UTI, or you got to know that you got to poop, or that you got to pee. So any AD moment where your blood pressure rises, I'm going to tell you, for my experience, is always bowel and bladder. Now, again, there are other circumstances too, such as cutting yourself or having a sore. But nobody knows more about you than you. So don't allow another people who don't know AD to make those decisions. At least that's my thoughts. We need to know about our bodies.
Thank you, Don. Yeah, so AD is pretty important, and it's worth knowing about your body and AD and your body. Absolutely, especially if you don't have the opportunity to meet with someone who specializes in SCI medicine, they might not know. So you talked about a suprapubic catheter, and actually I want to pull up in the chat because there's been a couple of chats here. So we have Deb, who says that her son uses a suprapubic catheter and takes oxybutynin. Hasn't had any problems or infection in 5 years. And seems to be a good fit for him, and he's got a cervical lesion. So that sounds great. But this is not unusual. A combination of a catheterization strategy for emptying the bladder and oxybutynin for maintaining continence or a relaxed bladder and keeping the bladder pressure low. That can work. So a lot of different things can work for different people. It's really good that, you know, they've had a good experience with their clinician to find a strategy that's going to work for them. For some folks, that suprapubic line, you know, can be really good because it's convenient. If they can maintain it, you know, that's really good. So I think it was Rhonda, you said that there was some good and bad with the suprapubic. Can you talk a little bit about what you like and then what you don't?
Well, what I like is that I drink a lot of water. I don't know, 16 ounces a day. So I'd be peeing a lot, which isn't bad. I'd get more practice transferring. What I like about it, well, that's probably about it. I mean, I don't have to get up in the middle of the night and pee. That would be it. I mean, I'd rather have control of my bladder and go to the bathroom like a regular person, but they haven't taught me how to do the routine on the toilet, so I've never peed on a toilet. It's been like 2.5 years. That's okay. That's
Okay.
it.
All right. Yeah. So we hear a lot about there's some things that factor in. So when we figure out what's going to be a good strategy for someone, you know, we want to know what their lifestyle is, what their goals are, what their capability is. So if someone does not have good hand function, or if they can't do transfers well, that may focus them in on one set of things they can do. Or if they have really good hand function, they want to have a lot of independence, and then maybe some other things they could try. So it's nice that we have a lot of these tools to offer, but none of them really restore the function. And so we think that there's still a gap here that could be filled that I'll talk about. Before I move on to bowel, are there any other questions or comments anyone wants to offer about bladder function? We have someone on here in the chat saying that they still get constant urinary tract infections. And another person is saying that they've got that they are starting to experience leaks, and is it to get the Metronoff, which is a procedure to have basically a kind of port or stoma. So I cannot answer. I'm not going to act as an MD. I'm a PhD, so I'm not going to give any kind of medical advice to anybody, except maybe talk to your doctor if there's a question. But so I can't answer the question about whether or not it's too late to get something like a Metronoff. But if you're starting to have change in your function, that's not unusual. So as any of us, as we age, we're going to have changes in our bodily functions. But certainly with the spinal cord injury, that's something that, you know, that you may have a good routine for 5-10 years, and then your body changes, and you have to adjust your routine, and you may need a new set of tools or strategies. Yeah. So let's move on to the next category, bowel. And we know a little bit less about how the bowel works compared to how the lower urinary tract works. So I'm not going to put up the same diagram with the nerves. It's the same neural structures, the same nerves, same pathways for the most part. There's a lot of overlap in how the bladder is controlled versus how the bowel is controlled. But we know that, so one of the things I want to point out is just how complicated the bowel is. It's not just some tube. There's a lot of neurons as part of that tube. It's a very intelligent organ. And I hope I don't gross anyone out, but if you look at like an earthworm, for example, an earthworm doesn't have arms and legs and a brain. It basically functions like a moving colon, and it's pretty sophisticated, in fact. Now we have a bunch of extra parts and pieces to move that colon around and put food into it, but there's a lot that it's supposed to be able to do on its own, but it still has a relationship with the central nervous system. So when you get a spinal cord injury, there are still some things that happen. So we see, I'll go on to that. We do see slowed motility. That's a big one. It's a very big one. There's diminished sensation and control of the external anal sphincter. So we have an exquisite amount of sensation at the anal sphincter. We have an ability to tell, that organ should be able to tell the difference between whether there's going to be gas, liquid, or solid at the rectum coming out. And if you've had a spicy meal, there are capsaicin sensors. There are sensors there that could feel if there's something's too acidic or spicy or something. So, or if there's damage, pressure sensors and things. So there's a lot of sensation at the very end that can be compromised, and also so that makes it rather difficult to manage one's bowel if you can't feel what's happening there. Then also if the reflexes are affected. So the mechanisms, the way the nervous system controls all of this is not as well understood as we'd like it to be, and not as well as understood as our understanding of how the bladder is controlled. But we know that there's chronic constipation and fecal incontinence that really affect quality of life. We know that the bowel routine can be 1 or 2 hours long or longer. For some people, that's 1 day a week. They're planning around that. That's their day. That's their bowel day. It often requires caregiver assistance with the bowel routine. And so this is another area that we're looking at is, is there anything we do for helping with bowel emptying, anything for improving continence? And so again, in that same survey, we asked people, so, what challenges did you have in the last year with your bowel? And we're seeing a lot of folks with constipation and fecal incontinence. We're seeing folks with loose stools. Hemorrhoids is a big issue, and bleeding related to that. So then that seems to be associated with digital rectal stimulation for emptying. And again, autonomic dysreflexia is coming up. And we asked them what their priorities were for getting function back. They would tell us that they wanted to maintain fecal continence. That was the number one thing. I want to be continent of stools. And then kind of tied at second place, they wanted predictability in the bowel routine and a faster bowel routine. So for someone taking 15 minutes to empty their bowel, maybe they're not complaining, but if it's 2 hours, that can be unreasonable. A lot of folks wanted independence with their bowel routine. They don't want to rely on a caregiver or a family member to help them with it. They want a sense of bowel fullness. Like, how do they know when they need to empty? How do they know if there's something going on? So those are the kinds of things that came up talking about bowel function. And so I'd like to switch the topic from bladder to bowel. And we have a couple comments already. So here's someone was recently diagnosed with ulcerative colitis. And would this benefit me with the colon device? And we haven't talked about a colon device yet. But we will be talking about some of that. But right now, I'm not aware of a device for ulcerative colitis, but that doesn't mean there isn't one. So that's something that I can look up and respond to later. What I would like to do is talk about the kinds of things that people are doing to manage the bowels. Are they happy with how that's going? Do they have frustrations? Things that, gosh, I wish this weren't a problem, and it is. And what are your experiences like with your bowel function? What are the things that you would like someone like me to hear, knowing that I'm going to go back to my lab and try to come up with something? Then I want you to know that everyone's stories are really valuable. So, thank you for sharing. I realize these are very intimate topics, and if I'm challenging anyone's comfort, I apologize. But thank you for being open and contributing if you're interested.
I hate the bowel routine. It's every day, and it can take 2 hours, and I dread it. And if I set up like Netflix so something's good, I can watch during and waiting and all that, it's better. But it's a drag. It's just a drag. I don't like the tools. I did find a really good tool because I couldn't reach with the enemies, that little squeezy thing.
Yep.
I found a blue thing called some kind of shooter. It's about that long. It's blue, and you like inject it. You put the stuff in there, and it's farther away, so you can get it in without being right on your rear, and you can put it in that way. I couldn't do it without it. It's a difference between having someone else squeeze it and me being able to do it.
Yeah, so those are really excellent points. A lot of times folks need help because it's hard to, again, if you have difficulty with hand function or transfers or balance, and you're trying to reach back there to do something, that can be challenging. And folks have to be lying on their side on a bed, and then you're trying to control for keeping things cleaning up when you're done. That's a drag.
How do you clean up when you're done? I can't use on the toilet, so I'm laying on the bed. At least I'm now using them on my left side, and that really does help. But I can't clean up very well at all.
Yeah.
I'm trying to hold mirrors so I can see what's going on. I can't hold 2 mirrors at the same time. I don't know. I haven't watched any YouTube videos though. I've been afraid to watch them.
Yeah, but you're able to do this on your own.
Yeah, I don't know. Someone else cleans up. I mean, everything else.
Okay.
I can pull away. Like if I put like 2 diapers under me, or they do, but I need to practice that. I can pull away the first diaper, and then I can lay back without laying in something, and that's very helpful. But trying to wipe up and not having a visual is hard.
Mm-hmm. Right. We had a question in the chat. What is continence? And if there's a word I say that you want to have defined or explained, please let me know. I apologize if I'm using jargon. So continence, the opposite of incontinence. Incontinence means you're leaking. So if you have urinary incontinence, it means you're leaking urine, you're leaking pee when you don't mean to. If you have fecal incontinence, it means you're
I don't know what you're talking about.
you're leaking stools or poop. So continence means the ability to control your bladder and bowel and be able to store urine and poop, feces without them leaking. And that's a major goal for a lot of people's not leaking, not having an accident. We have someone volunteer. They do their son's program every night around the same time and have found that the Magic Bullet is the best product. They found to use. It's from Allegra Medical, and you can get a box shipped every 90 days. Yeah, so the Magic Bullet is a suppository. I believe it's a stimulant, and it can get things moving. So if you can stick a suppository in, that's good. If you need help, you might help putting the suppository in. Can you get it in, far enough, and then cleanup is still an issue. So it sounds like for a lot of folks, they're either doing it on their own, and there's still some logistical challenges, or they've got to have some help, especially with some things, at least like cleanup. Has anyone ever used a device for getting the stool out, getting the poop out? Or does anyone here use what's called digital rectal stimulation? That's basically something like a gloved hand, fingers that go up into the rectum and manually kind of stretch out the rectum a little bit to get the stool to move. So if you have constipation issues, that may be a normal part of the routine for some folks. Just to get the stool to come down into the rectum so it can be emptied. For some people, the suppository is enough.
I found a tool for that.
Mhm.
And I found out that I don't have to do it as much as I thought. Just a little here and there, and then waiting does good. I have that thing here. It's what you put in the enemies into that. You hold it up so it doesn't come out, and you do it up to where you have to, and then voila.
Yeah.
Okay.
And are you satisfied with having to stick things in you like that? That's not a problem?
I don't find it very satisfying, but it's a means to an end. That was a joke.
Yeah. That's good pun. So some of the things that we're thinking about and I'll get to some of the devices that we do here in Cleveland in research. But we like to know, what is someone willing to try and use, or what is like, I don't want any part of that. I don't like what that's doing. So for example, someone might not want any surgery. It's like, if I say, oh, here's something that it requires surgery, but we can do this. Someone might say, I'm not ready for doing surgery. That's not the solution for me right now. That's fine. Or someone might say, yeah, I'm okay. If I'm already sticking a suppository in, if there's something else I got to stick up there, let me know. If it's going to address some of the other issues I'm having. So these kinds of stories are really helpful. And I'm seeing that there are a number of people that use digital stimulation. Those of you that are doing digital stimulation, how many of you are doing it on your own? How many of you need help to do it? You can put that in the chat if you want. And one of these days, I'm going to figure out how to do polls on Zoom. So we can set it up as a poll. But when we did our survey, we found that most folks needed some amount of assistance in their bowel routine. Okay, some folks that can do on their own. Maybe some people need. All right, so most people are doing it on their own, and some people need a little bit of help. Okay, great. So what I'd like to do is talk a bit about what we've got in research. So we'll talk about continence first, or holding in your bladder, your urine and your poop. So in this same survey, when we're asking all these hundreds of people, we asked them, what if there were a device that could help, right? So my background is in engineering. I'm an engineer and also a scientist. And I've learned, I use sort of the language of the nervous system, which is electrochemical signals. So I find that if I give the right pattern to the right nerve, I can affect some function, an outcome. So for example, if I give the certain nerve a certain signal, maybe I can get it to relax the bladder. Maybe I can get it to empty the bowel faster. So I try to find the nerves that are responsible for this and give them the right message. And there are devices that are out there. So this is all, we call this neurostimulation or neuromodulation. They're different words out there that have slightly different meanings, but basically what we're talking about is using very mild electrical pulses from a device that tells that nerve what it should be doing. Because if there's a spinal cord injury, the brain might not be telling that nerve what it needs to hear. So we put in like a little mini brain that tells it what it needs to hear. And the device, such a device could be completely external, or it could be implanted under the skin with a surgery. And so if any of you are familiar with, say, a TENS unit, these have been offered in the past for things like back pain. Yeah, it's all external. You have sticker electrodes that go on your back and a device you can hold in your hand that's wired to those sticker electrodes in the back, and you can turn it on and get like a kind of weird back massage. So there are a number of devices that use that kind of idea. And then there are devices that get implanted, and there are devices on the market right now that I can talk about. That go into your body. So we asked people, would you tolerate an implanted device or an external device if it helped you with any of these goals that you had? If it improved your urinary continence, your bladder control, if it reduced urinary tract infections, if you could empty your bladder without having to use a catheter, would you use a device? And so blue means yes and red means no, but at various amounts. So a dark blue is a strong yes, and a dark red is a strong no. And white in the middle is sort of a neutral. And so for external devices, half the people that we asked would say something basically, yeah, I might try a device using electrical stimulation if it's on the outside of my body. Yeah, if it actually worked. What I was surprised by was the number of people that would be willing to try something that was implanted in their body. I actually thought it would be lower. So at least a third of people were very likely to try something, and over 40% of people were at least somewhat likely to try a device if it were implanted. And that's not something that we talk a whole lot about unless you're talking to a doctor and you've gotten that far. So really quick, a couple of devices that are types of things that are on the market for bladder and bowel. There's a device that does something called sacral neuromodulation, if you ever come across that phrase. But there are a couple of companies out there that have a device that can be implanted to stimulate the nerves of your spine. And this is something that is for people with overactive bladder, but not necessarily for a spinal cord injury. So there haven't been the studies for this in spinal cord injury. Posterior tibial nerve stimulation. So this is a needle in the leg to get to the tibial nerve. This is done as an outpatient procedure over the course of 12 weeks. So there are companies that sell a device for this, and you can go to an outpatient clinic. But again, both of these, there are companies that exist, there are devices on the market, and these can be, someone can work with their doctor to get to this. And they have shown improvement in controlling the bladder and the bowel, but there is not really evidence for improving that control if you've got a spinal cord injury. So that's where it gets to be a bit controversial. So if you're sitting there with a spinal cord injury and you're saying, well, can I go to my doctor and get one of these? Would that work? And we just don't have enough information to know if that would work. So we have another approach, though, that we have been testing, specifically with people with spinal cord injury, right? So we've been, I care a lot about spinal cord injury. And when I look at the market and see that there's a lot of things that can help with bladder, but they just aren't trying this out for people with spinal cord injury. So, well, let's address that. So this is, I took these drawings from papers I've published, but the things that I want to draw your attention to are that this works in men and women. We've tested it in men and women with spinal cord injury. It's completely non-invasive, so you'd put little electrodes on the skin at the pelvis to target the part of the pudendal nerve, right? And we can measure bladder pressure. So any of you have had what's called a urodynamics examination, some of this might sound familiar. If you've not had a urodynamics examination, I'm happy to answer questions about that. But basically, there's a test your doctor can do. It takes about an hour or two to do it. They fill up your bladder with saline, and they measure how your bladder behaves while they're doing that. To say, okay, is your bladder contracting when it shouldn't? Is your sphincter contracting when it shouldn't? And they use that to figure out, like, should we be giving you oxybutynin? Should we be doing a Botox injection? What's going to work for you? So this figure I quite like here, that shows that if we're measuring your bladder activity, what is your bladder doing? This blue curve is showing a contraction. The pressure goes up and up and up. And this person would be leaking. They'd be having bladder urine leakage from this. That's what this blue wave is. We don't want this blue wave. We want this blue wave gone. So the red wave is, we apply stimulation after the red wave starts. So you see the red wave is coming. Oh, we're having another contraction, right? Maybe this person feels urgency and they say, oh, I gotta go, I have to find the restroom. I'm gonna have an accident. So we turn on stimulation. That's this black bar here. We turn on the stimulation and the pressure comes down. We stop the contraction while it's happening. This is an example of the kind of evidence we look for to say, okay, does our thing work? We have to have a lot of rigor in our work if we're going to claim that our thing works or does anything or is a help. So in a lab setting, we know what this approach can do, but then we want to send people home with it. So in a lab setting, we know that we can keep your bladder calm, but what happens when we send you home with that system? What does it do for you? And so we sent this home with a few people for a few months, and these are not pictures of them. These are representative from the stories they told us. So there was a gentleman, spinal cord injury, I think it was AISC, so he's pretty functional. He's also very active. These are all people that wanted to be active, and we have a lot of anecdotes from what it meant to them having this ability to calm their bladder down and stay dry. So there was a gentleman who would go on trail bike rides, and instead of stopping every hour, he went for a 4-hour ride and didn't have to worry about getting wet or dealing with his skin getting wet. We had a lot of the time people would tell us they're not constantly looking for where the bathroom is. They know they'll be dry for longer, so they're not constantly figuring out where the bathroom is. Maybe they'll go for a long car ride that they wouldn't go for before. We had a woman who went to the hairdresser for a 2-hour appointment to get her hair done, and felt comfortable that she'd be dry for that appointment. We had a gentleman who was he was around the campfire with his buddies, and he said, I gotta tell you that this device wasn't working for me. It was working, but then last weekend when I was hanging out with my buddies, it just wasn't working. I kept on having to go to the bathroom. And I said, oh man, something must be wrong with the device maybe if it suddenly stopped working. So we were checking the batteries and we were looking at all the parts and pieces. Everything looked fine. And we checked, he tried it, and that day was fine. Come to find out, the issue was he was drinking beers with his buddies, and they were also getting up every half hour to go to the bathroom, just like he was too. And so this is not some kind of miracle that's going to allow you to hold 5 liters of fluid, but it gives some control back. So he wasn't having accidents. We had some folks that wanted to be able to get to the bathroom, and without the device, they'd say, well, if I feel urgency, I've got a minute, maybe 5 minutes, but I have to get to the bathroom or I'm going to have an accident. With the device, they'd feel that urgency, turn the device on and say, okay, I've got like 20, 30 minutes now. I can, that urgency went away. I'll be able to get to the bathroom without worrying about having an accident. Of course, there's always room for improvement with these things. So this is an approach that we're trying to improve on. We're working on developing a full prototype for this. So we sent people home with stuff that we were able to get from like Amazon, right? And it wasn't really made for this kind of purpose. So we're talking about sticker electrodes with long wires And so someone is trying to figure out, well, where do I put all the wires? How do I coil this up? How do I make this work? The electrodes are falling off. Why are the electrodes falling off? You know, so they're happy when the thing's working, but imagine if I gave you a mobile phone, right? But the mobile phone has, you know, wires dangling off and it weighs 10 pounds and the battery lasts for a half hour. You're gonna say this mobile phone's no good, even though it's all the other functions are good. So this is something that, you know, we're advancing. We know it can help. So this is something that I'd like to talk about is the kinds of things that we're developing for improving bladder and bowel control. We have so we have some feedback. Folks looks like they would try these electrical devices. We have someone, Greg, they had an InterStim implanted in 2000 and had it revised twice. It still did not work. And as it stands, the device is dead, but it's still inside of me. And the only thing that's made it work the best for me and worked for the past 10 years, the suprapubic tube. So, Greg, are you willing to unmute and, or if you don't, you want to just keep in the chat, that's fine. But I'd like to know what brought you to the InterStim device. You know, who did you talk to? What made you want to try it out? And how do you feel about it now with it just inside of you? And how did the revision surgeries go? Like, you know, do you want to tell your story a little bit for everybody?
What led me to this is after having several tests done as far as the urodynamics. See, I have two types of issues going on with my bladder. Not only the neurogenic, but I also have overflow incontinence.
Mm-hmm.
So I have both of them. Mm-hmm. And my urologist thought the best thing at that point was to try to use the InterStim because I was constantly having urine backflow into my kidneys. So I was having kidney infections along with UTIs.
Mm-hmm. Yeah.
So they were trying to stop the spasming so that they thought the InterStim would work. Well, this was the very first stage of when the InterStims came out, and they actually had to sew the lead into my spine. It wasn't where they can just use what they have is a lead that's put in by, you know, little spikes that go next to the spine, where mine was actually stitched into the spine. And the first time it was done at the Cleveland Clinic, the lead had not been attached very well, and it migrated all the way down my right leg. And I had to have it revised a second time. And no matter what setting they tried, they had the rep come out. And no matter what they could do, they could not get my bladder to stop spasming, even with medication.
Yep. Yeah. So this is something that we've been finding in the research is, so this is why I say it's a bit controversial. And so this is not something that I am doing my research on because the evidence I've found so far was just not very supportive of this direction for, you know, continuing with the InterStim for spinal cord injury. There are things that I think could help it work for spinal cord injury. It might be things like more leads and increase the amplitude, but that's a whole line of research to figure that out. And instead, what we've done is we've taken something that I was already showing some evidence, this non-invasive approach I was just showing you. So what I'm trying to say is I don't want to give the impression that I'm just saying InterStim's no good. If anyone is talking to the doctor and considering it, you know, talk to your doctor about it and consider the evidence and make your choice. So I'm not here to say, you know, thumbs up, thumbs down on something, but it's really valuable to hear that experience and just something may work and just the research wasn't done to get a sense of it or not. But as Greg, you're pointing out that there are these issues to be aware of. So when you've got an implant, what are the risks? Are you comfortable having that conversation about the risks with the doctor? So this is basically a risk of it didn't work. So the risk of infection from the surgery is maybe not considered too high, but that's a kind of personal decision you make about what's the risk of infection and how much do I want to deal with that. But there's another risk of what if it doesn't work and it's just in me, it happens. What if there needs to be a revision? Is that going to be okay? What does the doctor think about doing a revision if that's needed? And so some of these devices need have a part replaced or revision to it. That could happen. And some things have been around for long enough that we have a sense of what that is, what that risk is. So Greg, you're talking about how the InterStim had just come out. And so that followed on quite a bit of work in the lab first to get a sense of what was going to happen. But certainly after years and years of trying things out, they've made further improvements, like having an electrode that has barbs or tines on it, little spikes. So it's easier to put in or take out. And they can do these trial periods before implanting it. So there's a lot that's, we've learned in 22 years, but overall, what is your attitude toward that experience, Greg?
I think if they had a better understanding of the device and what it could do and where they needed to actually implant it, as far as the lead goes, I might have gotten a better outcome. I don't know. It's hard to say because it was just first approved by the FDA to be used way back in 2000.
Yep.
So there wasn't a lot of knowledge at that point. And that was, one of the things that doctor had mentioned to me, because my other alternative at that point was to have my prostate completely shaved off and open it up so it would just drain completely. And he didn't even offer the suprapubic tube. I had to do the research on my own once I found out this device didn't work.
Mm-hmm.
But I think if they had a little bit more knowledge at that time, it would have been probably a lot better outcome. But with the rep not knowing and it being a brand new device out on the market, there wasn't a whole lot of knowledge at that point of where to actually implant the device, even though they did a test run with it prior to implanting it.
Okay. Yeah, I want to make a plug for United Spinal right now because what we find is that, folks that are part of these groups have a great opportunity to learn from each other. And all of you are having to do your own research and be really savvy. And that's good that you'll take the responsibility for your care. But it's even better if you can lean on a community to help with that and ask questions or offer advice or offer your experiences. So I'm really happy that all of you are on this call and participating this way because that can really help all of us. So does anyone else want to offer anything about any kind of electrical stimulation device that they may have tried or heard about, or a question they might have? Yeah, and think about that. I'm going to move on to the last topic, which is emptying of bladder and bowel. So right now there is one device that's been commercially available, and FDA approved for emptying bladder and bowel after spinal cord injury. There used to be a company that in the United States that sold this device, but that company went out of business, and not because the device did not work, because of market pressure reasons that I won't go into here. But it is still possible to get this device in Europe, for example. So the way this works is this is an implant. So to get we're working on other research to see if we can get better bowel emptying without a surgery. But it is difficult to get to the nerves for emptying without a surgical approach. So we're working on it, but it is technically very challenging. If we're thinking about bladder and bowel control, I think we can do it non-invasively. We're talking about emptying your bladder and bowel non-invasively. That's still something we're working on. But what is available right now, you can have. So there's a surgery to get to the roots of your spinal cord at the very bottom here at the sacrum, right, and lower lumbar area. And then these electrodes are put on there. The electrodes run to a set of coils, a kind of receiver unit, and that stays under the skin. Okay, so just moving about, no one will know you've got this thing. When you decide you want to empty, you pull out this control unit that's about the size of a smartphone, and it's got a transmission unit that mates with the receiving unit. So you basically stick this unit on top of your skin where the receiver is going to get them lined up, and you turn on this controller. So, and that'll get your bladder moving, or it'll get your bowel moving, depending on which program you turn on. So there's a program set for the bladder and a program set for the bowel. So one issue is there's a surgery to put this electrode and receiver unit in. If you ask a neurosurgeon, they'll say, "Oh, that's no big deal." Because of course the surgeon's going to think a surgery is fine. But typically what they've done in the past, and this has been tested in thousands of people, but what they typically do is they'll cut the sensory nerves. So for any of you that are worried about your bladder bowel control, and you say, well, I'm having unwanted contractions of around my urethra, and I need to use a catheter to get past that, or I'm having bladder spasms and I get incontinence. If they do the nerve cut, those reflexes are gone, so you have better control. But it also means that any sensation you might have had is also gone. Any sexual function you might have had from those reflexes is gone. And so that may not be desirable for everybody. For some people, fine, cut those sensory nerves, I don't care. Maybe they don't have sensation enough anyway. Maybe, and they're having so much incontinence, and just they want this taken care of. For others, and we say, I don't want that. I don't want to cut the nerves. So we are currently looking at ways of doing the same procedure, but without having to cut the nerves. So we're currently studying this right now. Can we do this without cutting the nerves and still get the same effects by just changing the signal I give to the nerves? That kind of in their language, can I tell them the right thing? So we have a couple of things we've tried that are showing some promise. There's a frequency at 500 to 600 hertz. Pardon the data that I'm showing, but I think this is really neat. So pay attention to the red line. The red line is, this is the anal sphincter. We can see the same thing with the urethral sphincter, the sphincter on the muscle around the urethra. But basically, if you're having to use a catheter because you can't empty your bladder without a catheter, because it just comes out as dribbles or nothing. Maybe because you have this muscle in red here that's squeezing when you don't want it to. So I can get that muscle to squeeze, and you can see that the pressure goes up, right? But if I add on this pattern in this black bar, the pressure comes back down. So this is a relaxed urethra. This is a urethra that urine could flow through, and I didn't have to cut anything. I take that signal away, and the pressure comes back up. So basically, I can, open and close that urethra. And that's the thing that we want to, can we do this clinically, right? Can we make this a part of the way someone empties their bladder? And we have another thing that has a similar effect at a higher frequency, at 10 kilohertz. And so these are things that we understand what the safety profile is for these patterns. And we even have a device that can do it. So we're now starting to try this out in people with spinal cord injury. It's like, if we give this to you, is this something that you can use to empty your bladder? So this is the last discussion break. And so I'm going back to the chat window. Elizabeth says that she did the FES program at the VA in Cleveland and worked with Rudy. Oh, Rudy Kobetic, yeah. And electrodes planted in legs to help walk. Did that for about 4 years. Elizabeth, if I can ask, I'm familiar with that system, that you had the electrodes implanted in your legs for walking. And I realize that, today we're not talking about reaching and grabbing or walking or trunk support, and those are all important too. But I've got 2 questions. First is, what was your general experience like? Did you, positive, negative? Was there some good and some bad with that? How did you feel about your experience working with the FES program?
Actually, I didn't have a problem. Well, I did have one problem. I had my hip flexors, not my hip flexors, the ones, my buttocks I had implanted. We had to actually turn those off because the sensation that I had full sensation there. So every time I would use them, it would bother me. So we actually turned those off. That was the only problem I really had. I had one small little infection at one electrode, but I took an antibiotic, we cleaned it up real good, and I never had a problem. The walking, it kept muscle tone. I had no leg spasms at all. The only reason why I quit the program was because I started working, and I had a boss who knew when he hired me that there was at least one Monday a month I had to go up to Cleveland to give them my information from my little control. And he gave me such a problem that I actually just went up there and told them, I'm not able to give you the information that you need. I can't keep up with this because he's not allowing me to take the time off. So that was one of the reasons why I stopped the program. So, but other than that, I didn't have a problem with the FES with the walking stimulation.
Okay. Did you find any effects on your bladder or bowel from using that system?
No, I didn't. Sometimes when I would go to walk and stuff, just by gravity, I would accidentally have a bowel movement, but that was just from gravity standing and stuff. But I didn't notice anything with the bowel and bladder with those, because all the electrodes came out in my quads. They weren't under my skin with a device under my skin, I guess by my bladder. They were just starting to do that when I was getting ready to leave. And I didn't want to do that at the time because there wasn't any research that was out there if I would have become pregnant, what those devices would do to the fetus. I mean, to my legs, that would have been fine, but underneath the skin by my abdominals, I didn't want to do that. So, but other than that, like I said, I didn't have really, they got a lot of information out of me when I was in that program.
Excellent. Thank you for participating in that.
Not a problem.
It was mutually beneficial. I'm sure it was. Yeah. So there's a couple of good things that were brought up here. So there's a lot of things that we want to consider. Health and safety are really important. So we want to understand if someone wants to plan a family, what the effect is there, if any. I'll say this though, even if the electrodes are in the legs and not near the abdomen, there could still be an effect on bladder and bowel because there's a bit of overlap in the nervous system for taking in information from your limbs and taking in information from your pelvic floor that's part of controlling your bladder and bowel. So it's we are seeing some mounting evidence that there's a relationship between ambulation and bladder and bowel control. So we talk sometimes about, is there some research we can do in that direction? And right now we're kind of looking at, well, can we look at them separately first and make sure we understand separately and then look at how they relate to each other more. But there are some groups out there that look at how they're related. So I like asking that question because you never know. Someone might have said, oh, actually, I had better continence, or my bowel routine took less time, or no, there was no effect at all. I was able to stand up and transfer, and that was good enough. And that's fine. So we just try to keep an open mind for what might be happening or not happening. And are there any other any questions or thoughts that anyone wants to contribute about if you have if you're looking at a device like this, or you're hearing about, I mean, I'm telling you about research like this, there are other things out there that are also being researched. So I'm talking about what I have expertise in. This is the work that we're doing here in Cleveland. This is happening right around you. There are other groups in other places that are looking at spinal stimulation for spinal cord injury. They're looking at powered exoskeletons. They're looking at different medications, different drugs. So there's certainly a lot of things that are going on out there, and it can be a bit overwhelming, but it's at least cool to follow. And but I wanted to take this chance to let you know that right at your doorstep, there's a lot going on in Cleveland, and get a chance to hear what your questions might be and hear what your stories might be. So if they're, and I'm worried that I'm probably running over a bunch. But I want to thank everyone. If you don't have my contact information and you want to follow up with a story or a question or a comment or just chat with me, I guess, Megan, is there a way for them to get my email address so they can reach out if they want to talk to me about something?
Yes, when we send out the replay, I can include your email, your contact information, or
Great.
if you want to email the chapter before I get that out, I can pass along that information. The chapter is unitedspinalneo@gmail.com.
Okay. So yeah, what I'll do is, well, Megan, you've got my FES Center email address. So please feel free to share it with folks from your chapter that want to reach out to me about whatever. I'll stay in my lane. I'm not going to give medical advice that I shouldn't be giving. I'm happy to answer any questions and try to help you, point you in the right direction. But also I'm really interested in any questions you might have, any stories or comments you might want to offer that could help us. And if you want to hear about the work, I'm not going to press you into participating as a study participant. I'm happy even if you just want to know what's going on in greater detail, just to follow along with what the research is telling us. I'm happy to do that. But if you do want to participate in this research study, we can talk about that too. So I'll leave it at that. I want to thank everyone for a great chat and for being so open and telling me your stories. And again, if there are any final comments or questions, and I do have my chat window open here. And you'll have my email address if you want to follow up with me one-on-one. Okay.
Awesome. Well, people are thinking if they have any questions. Thank you so much, Dennis. That was wonderful. It's always good to know what's out there, what's current, what's been successful, all of that stuff. I'm going to go ahead and stop the recording now.